So it's not really about kind of trying to discuss it. It's more about trying to just bring out the issues and bring out the topic more fully, given everybody's experience and understanding. So we're going to cover 3 questions tonight. Let me just make sure that I'm doing this right. Aha. Oh, and that's the other key point to remember, is that when somebody's talking, we don't talk over them. So the person who's speaking gets to speak freely. And if a question comes up and you don't have anything to say about it, you can pass, but you can also come back and indicate that you want to say something later if that happens. And so the questions for tonight, the first question is this. Introduce yourself and also maybe talk a little bit about what inspired you to come along today to this melting pot. So we might start with Lindley.
So I'm Lindley Jordan. I practice in Brookvale in New South Wales in Sydney. My clinic's been going for nearly 35 years. I practice with a bunch of other homeopaths, and there's some nutrition and naturopathy and bioresonance thrown in there. I guess I've been writing up my cases for a very long time. I've published quite a few of them, a lot of them in Similia, some of them in ATMS Journal, some of them in Wellbeing Magazine, all those kind of places. It's interesting when I look back at those cases now, thinking what could have been done differently, what could have been done better, looking at the beautiful criteria and checklists and guidelines that have been written up in just maybe since like 2014 or whenever it was, thinking, my goodness, there's a lot more sophistication and elegance in what's being done these days. So that's really what promoted me to want to join in this melting pot tonight, just to think a little bit more deeply about it and hear what you other people have to say on that topic.
Well, thanks, Lindley. Caroline, would you like to go next?
Sure. Okay. I'm Caroline Hayward. I've been a homeopath for considerable time. I also practice craniosacral therapy. And I moved to Queensland 2 years ago, and just sort of starting to settle into the neighbourhood, so to speak, which is where Cindy has been most helpful, as she lives down the road and she's the Queensland president. So we see each other a fair bit, which is nice. So yes, I spend a lot of time reading and researching, but I don't have much in the way of a practice at the moment. Probably because I haven't, I've been too busy doing other family things. So, but I am cogitating over writing a book, but I've been cogitating on that for the last few years. One day it might come out. I have all these ideas, but taking copious notes and listening to lots of webinars and keeping up with what's going on in the world of homeopathy. That's me.
And what's inspired you to come along today?
Oh, sorry. Yeah, well, to see what everybody else is doing and just to keep in the swing of, whatever everyone else is doing. And as I know you all a little and have seen your faces many times and been to conferences and that, it's nice to hear what other people are doing and how you're getting on in practice. And
Lovely. Okay, thanks, Caroline.
Thank you.
Ilma.
My name's Ilma Heinzen. I've been in practice as a homeopath since 95, I think. I moved to Australia in 1998, where I settled in Sydney, and that's where I became very connected to Linley and a few other homeopaths at that time, and we've still got kind of strong connections. I then moved, still in New South Wales, to Yamba, where I lived for 14 years and helped set up the Wellbeing Centre there and started to do research. So I have just a small kind of clientele, but the research that I did in Yamba was mainly to do with mosquito-borne viruses and then developing the product Itch Goes. So that is where a lot of my time is taken, still in kind of making up the remedies, sending them out to people. But I've got so much interest in lots of different things. I'm on quite a few committees. And when Celeste became the new editor of the Similia, I congratulated her, and then she was talking about what she wanted in the first journal. And I put my hand up. So I have been part of Melting Pot a few times. I was over in Bali with Linley and the team, and I can't remember, was it 13 and 15, Linley?
Yes, 2013, 2015.
Yeah, so that was a great experience. And I just love being around my homeopathic friends and learning more about what's happening in homeopathy around the world. One of the best kind of volunteering jobs I think I've got personally is being on the webinar committee, because I get a chance to speak to any homeopath in the world. So for me, it's delightful because I'm just a communicator, really. So, and yes, doing this evening, I was inspired to do it because this is what Celeste and I have been working on for the article that's going to be in Similia. A fabulous case that, my patient has been so lovely in helping us kind of give his journey as well on well-being with homeopathy. It's just delightful. So I'm very happy. Thank you.
Well, that's good. Well, I'm Celeste Salter, and anyway, yes, I set up this melting pot on case reporting. Basically to help kickstart the conversation for practitioners to look at what is inspiring them to write up a case and what is stopping all of us from writing up our cases. It's potentially a big issue, and the three questions that, or the two further questions that we've got to look at tonight are really trying to begin that process of trying to understand more about what some of the obstacles are. Maybe that's a strong word, not sure. It's definitely an interesting topic, and I'll go into a little bit more detail about some of the background that led to this as well. But as Ilma said, I've just become the editor of Similia, and one of the things that we wanted to do in Similia, we meaning me and the Homeopathic Association, is to have more cases in the journal. And so then the question is, well, we're all practitioners. How do we bring our cases into print? And as Linley mentioned earlier as well, there's been more guidelines in the international homeopathic community about what a good case will have in it. And so bridging that gap between the two things is kind of one of the issues that I'm kind of exploring, in particular, say, with Ilma, who very kindly stepped up and said, yes, let's work together and figure out what it would take to transition our understanding of a case into a new understanding of a case report. So, that's kind of why I'm here. And maybe also I'm sort of like tentatively thinking myself about how would I do a case myself, because I've not published a case before. I'm glad that Linley has. So we've kind of got, some people with experience. And Caroline, have you published a case before? No. Oh.
I've had many that I've thought, yes, I could, and I should, but I haven't. No,
that's okay. We'll get there. One of the I might just move on, if you like, into the next little bit, because there's sort of some information that I'd like to share with you all that some of you know bits and pieces of, and others may not know any. But all of us are aware from our training that cases are the fundamental place where we find out how the remedies work, because that's the experiment, if you like, with the patient. They take the remedy and we see it happening in real time. It's not theory anymore. It's turned from theory into practice. And, when we're reading things like from Hahnemann in the Organon, this too is part of that fundamental process that is fundamental to our profession. But we also know that many different disciplines inside homeopathy, different approaches, have different ideas about what is a case, or how do we take the case, what kind of methodology do we use. Is it Kent approach? Is it levels of health? Is it sensation method? Is it a pragmatic approach, miasmatic approach, kingdom approach? There's like a growing number of different lenses and windows that we can look into when we're inside the practice doing doing the craft. And we also know from reading Similia, I don't know if you've had the pleasure of reading any very old British homeopathy journal cases, but sometimes a case would be 2 centimetres long in a column. So there's kind of like a couple of symptoms and we gave this remedy and it worked, and that's kind of like the sum total of case reporting versus, several pages long and detail about the background of the case and the patient and the conditions, and a progression of remedies being given and cure occurring for the person. So there's a lot of things to consider about case reporting. What's the right way to do it? And also, one of the key things that had happened, probably in alignment with the big attacks on homeopathy in the mid to 2010s onwards, is this allegation that homeopathy doesn't have any evidence. And one of our key parts of evidence is the case report. And then inside that context, the homeopathic community internationally, the research people that are doing research in homeopathy, said there's no consistency across different parts of the world, or even inside different disciplines, on how people write up a case. So this makes it really difficult to use cases in research, because they may have parts missing that would make the case more standardised in terms of its content. It's not to say that what was done in the case taking is wrong. It's just the reporting of it wasn't full enough or standardised enough. So, and earlier researchers like Robert Van Hasselen and Michael Toit, a few other people whose names I just don't remember at the moment, have come together and put together a set of guidelines on what a good homeopathic case would have in it. And so a bit later on I'll go through those with you, but that kind of standardising process actually comes from medicine. And then the homeopathic doctors that were involved in this international effort for medicine to make a good case report expanded those criteria for the homeopathic approach. And when you read those guidelines, it can be quite daunting sometimes, because, they're using scientific language. It kind of seems a bit separate to what we do when we're in the clinic. And but it isn't. It's just a barrier of language to overcome and understanding. And And I think the imperative for our homeopathic community to bring our cases into print, a good case into print, is really important. You could just sort of think, if there's how many hundreds of thousands of homeopaths around the planet, if everybody published a case, then all of a sudden there are this many hundreds of thousands of pieces of, evidence that of one situation that has had a benefit from homeopathic treatment. So that's kind of like, we've got a lot of hidden possibility in our filing cabinets and clinic notes that, if we could turn it out for people to look at, it would be very good for us. There's also just a little bit of a criticism sometimes about cases, in terms of saying that it's very low level research, like it's almost is kind of like this turning away from a case report as if it's not important enough. But then inside homeopathy, they've actually developed a kind of an assessment criteria, which has got not a subheading, an acronym called MONARCH. And by applying this particular criteria to the case that's been analysed, you can essentially move the case from being an observation into saying that the treatment caused the actual outcome for the patient. This is a very powerful additional tool that is being used in papers. And if you read in 2023, the June edition of Similia, there's a case report for the treatment of a breast cyst, which has used this MONARCH assessment criteria very successfully. So now this case report that is in our journal, somebody can come and use this as a piece of research and add it to their research efforts if they're looking to, say, look at how homeopathy could be used in the treatment of breast cysts, for example. So that's one of those things to kind of put in the background. But I was wondering, maybe we could move into the next question. And I just want to make that happen there. And, this is the killer question. So, yes, would you like to consider this question? Why have you or why haven't you published a case from your clinic? It's not an interrogation. It's more like an exploration of, what the motivations and issues have been, so that we can all begin to understand more fully, what is it that's underlying what we're doing. I wonder if, Lindley, would you like to go first?
Yeah, sure. So, first of all, why have I published a case before in my clinic, from my clinic? So I'm just remembering I wrote up a case of a constitutional gelsemium back in like 1990. I don't even know when it was. It was in Similia, early 1990s anyway. And why did I write it up? Because it was just so exciting about the response that the guy had. I'll tell you a little snippet of it. He was a pilot with one of the big airlines flying around the world, and he said one of the most terrifying parts of his job would be to, I think it was every 3 months, do one of the simulator exercise things where they'd, be sitting in a chamber and their plane would crash and they've got to work out what to do, and he would be an absolute wreck for however many days beforehand, and it was destroying him physically. He was, really suffering because of it. And the gelsemium, in a whatever potency it was, absolutely worked so well for him that his physical symptoms stopped, and he was able to continue his job. I can't remember all the details anymore, but I guess back then it was because it was exciting. It got a great result, and you might as well write it down, and it's just fun to be able to record it. And I haven't pulled that out and looked again at what I wrote, but I imagine if I did now, I'd be a little bit like, oh my God, So that's the kind of thing that would have stimulated me before to publish a case. But more recently, about publishing some of the other cases that I have I find it quite daunting. Or actually, the other day I was thinking, how many cases are there in the filing cabinets over 35 years of working? We know that not every case has a marvellous outcome. It would be great if they did. But, there's some great cases. We've all got them sitting in our filing cabinet. And when I think about the criteria now for publishing, I find it quite daunting thinking maybe the case isn't as good as what I thought. Maybe I didn't collect enough detail. Maybe I could have more carefully looked at the outcomes and tracked it more carefully. And I guess it starts right from when you're taking the case, when you're writing it down, to keep enough detail that you can publish it later and match it up against the guidelines and the criteria. And Van Hasselen was saying about it's not just us in Australia who might feel like that. He said it's a very global phenomenon that everybody feels like as if their case taking could have been better. It's not good enough. There's common kind of thread running through homeopaths around the world. It's not just Australia. But the other point about this is about why the question for me would be, why haven't I published a case recently from the clinic? Because I would like to do it really well, and that's the daunting part of it. So, but I might just mention here too that when we've been looking at lots of literature written in Australia for scoping systematic literature review, everything since 1990 we've been looking at. The cases that are written up are often written up in the most beautiful fashion, telling a beautiful story, starting from here and ending up over here in a lovely result in a cured case. But it will be not just this straightforward thing. It'll have a little bit of case history in there. It'll have some materia medica. There might be a bit of approving. There might be a list of rubrics. There might be some self-reflection by the practitioner. Maybe they'll have a little paragraph said in the patient's own voice. So I think that's one of the challenges for me personally, is thinking about being able to go through some case and be able to report it in a beautiful fashion, sticking with the recent updated guidelines, but also be able to tell it in a fashion that's authentic to my own writing style, and include some of those lovely things that Australian homeopaths are so good at doing. So that's probably enough of an answer about why haven't I published a case recently.
Okay, thank you. That's good. That's excellent. Thanks for sharing. Caroline, would you like to have a stab at this?
Have a stab at it.
Yeah.
Yeah. I listen to you all and I think, oh goodness. I mean, as I said, I listen to so many webinars and all these wonderful cases that are sprouted. And, I've never felt that I'm capable of writing something up, really. I find myself very critical of what people write up, how they write up their cases. And they vary so much. And sometimes it can be a long story or a short story, but if it's written as a story, I find that's more engaging than anything. And I've written a few things, but I've never actually got to the point of publishing. As I said, I've thought about it. Yeah, I mean, there'd be a couple of cases of recent that I could have written up. I think a lot of ones that I've read, I can say that they're not comprehensive enough, in the respect that the reasons behind prescribing a certain remedy or remedies isn't sufficient, and the follow-up isn't sufficient, or if there's any at all. to see how that person or those people responded to those remedies. And there's a lot of other questions I have in my psyche that I ask about these things, and I suppose it stops me. But yes, I would like to do it one day. Try. Yeah.
Ilma, I'm going to speak next, if you don't mind, and then I'll ask you to speak.
I enjoy listening.
I just wanted to change the thing because of something. So I really appreciate what you were saying there, Caroline, and Lindley both. I've not published a case either myself, and so I kind of noticed that, I feel a little bit gung-ho about publishing cases, and I haven't done it. And I haven't done it. And I've been spending, particularly since talking with Robert Van Hasselen, he was talking about this this thing called positivity bias, which is something that the whole of our profession gets kind of slammed with, that, we only ever publish positive things. And so we're in this kind of Pollyanna delusionary state that, homeopathy is fantastic and not real about it. But whether or not that's true, the flip side of this is exactly that thing you were saying, Caroline, which I suffer from as well, is that I don't have anything quite good enough to meet the unrealistic expectation of perfection. And I'm laughing about it too. And and then it rankles deep in me, like, surely, and I know I've got some really interesting, cases, even ones that aren't solved, like in that sense, but where that what you're doing with somebody is helping them, and there is positive movement in their health and well-being, and it may even be positive movement, but not necessarily about their diagnosed disease, but there's a a general well-being movement. And so I kind of, so one of my motivations, I guess, is that I don't want to be seen to be deficient and lacking as a homeopath. So it's really hard to, write out my method, if you like, and show people what that is. And so, that kind of, I think it's something, if we look back in the cases, this is something which is missing often, is that there's an assumption that we all know what the homeopathic case taking process is, or whatever that is, and the focus is on the giving the remedy or matching the remedy to the condition and showing this positive outcome, which is good and interesting, but it's not full, and in a sense it's sometimes not real. So anyway, because I'm in the middle of this process myself of trying to encourage people, I'm really being confronted by this question myself, and I confessed this to Ilma the other day. So because she gave me forgiveness, which was very kind. So,
is it possible for me to say something?
Absolutely, yeah.
In response to you, no, it's occurred to me that there's nothing written in our literature that I've come across to give the criteria or a list or guidelines or whatever of what to put in a case or how to write up a case or exactly how to do it. And I think if there was that, a nice synthesis of what should be in there that is most important, most relevant, Not a lot of wishy-washy stuff, but really nitty-gritty stuff. How to do it. I think there'd be a lot more,
Well, fortunately, Caroline, there is such a document now.
Oh.
So, yeah. No, it's good. And just when we move along into the next round, I'll share the guts of it with you,
okay.
and I'll send you a copy as well, because it's it's exactly important. Exactly important. But what I might do is pass it to Ilma now. So, Ilma, would you like to have a go?
Okay. I think because I'm a very practical person, the things that I remember are the acutes that kind of just hit you straight away. You know, when you give somebody arnica and they're kind of spurting with blood because they've cracked their head on kind of a stone step, and you give them 3 doses and you literally see it be sucked back into the wound and things like that. Those are the things that stay with me. And of course, you can't write a lot about that other than kind of what's happened. So I think Celeste, and also like doing the research with Ichgos, because it was practical. People took away the remedies, they got bitten and stung, they kind of tick boxes, and I just analysed it all. So for me, that's easy. But to actually write up cases, I've never really thought about it until I approached you and we're doing it. And I realise, like what Caroline's just said, there are, yes, if the criteria is there that guides us in doing it, it's a lot easier. But there's so much in that criteria that didn't occur to me at all. One of the things was reading more about the condition that your patient's actually suffering with from all different levels, traditional kind of medicine, as well as kind of being treated homeopathically or with Ayurvedic or whatever medicine. It's a great big picture, and us doing the timeline, for instance, is very important as well, to be able to see the reason why remedies were changed and what was going on at that time. But I feel that the most important thing to me in what we're doing is the patient's point of view. To actually have his journey in his own words put into this kind of paper, I just think is beautiful, because we don't normally do that. It's our point of view, the reason why we've given remedies, what the outcome's been. All right, the outcome is the effect of what it's had on the patient, but we don't often hear all their words and their journey into getting to that place. I think that's the most beautiful part of what we're doing, Celeste. And it's important, the other things which are making it, come together. But that is a good part for me.
Well, I might just, the reason I asked you to go last, Ilma, because I knew you were going to talk about this case and I wanted to keep going a little bit further. And so I want to bring up a couple of things. Ilma has a client who's agreed to allow his case study to be published. And so we've been using this as a test case for both of us to see what would it take to take the case that we think we would write and turn it into a case that will meet the criteria of the case reporting guidelines that have been published in 2022. Started in 2016 and revised in 2022. That's the Homeopathic International Community Guidelines. And they're called HomCare, homeopathic care. Homeopathic case reporting, that's what it stands for. And so Ilma's particular patient has got Meniere's disease. And so first of all, I wrote down a case of Meniere's disease. And then I added for a patient. And then I wrote the sentence properly with the patient at the front and centre because it's just that Ilma's patient happens to have Meniere's disease. So already just at this very beginning fundamental thing, we've got this kind of, dynamic thing going on between, looking at the condition versus looking at the person. And so like all the way through, we're in this kind of, I'm moving my hands like this in this to and fro between two different ways of thinking potentially, or two different dynamics. Earlier, you mentioned about the narrative or the story, like when somebody writes the case as a story, it's engaging. And one of the things talking with Ilma that sort of really come out is that the entire discussion that we have about what's happened in the case, it is a story. There is a to and a fro, and there's a discourse and a dialogue going on between me and Ilma when we're talking about it. And then how do we translate that just right into the page, like right down into the case? And then there's this tendency to extract all of that stuff and just pull out pieces of facts, if you like, or pieces of data, which we are trying to encourage ourselves not to do. To put in the not colourful, but put in the bigger, broader context. And when I said to Ilma at somewhere along the way, we talk about homeopathy, but it's Ilma's homeopathy in this case that Ilma's done with the patient with Meniere's disease. It's Linley's case with the guy who's flying the aeroplane and needs a gelsemium. Like if it wasn't Ilma and it wasn't Linley and it wasn't Caroline and it wasn't Celeste in all the particular cases, then it could be artificial intelligence. So what is it that's specific? It's the fact that the person's come to Ilma and didn't leave Ilma and go somewhere else but stayed there. That's still part of the dynamic of the whole process that's going on. Do we say the homeopathy is just giving the remedy, just figuring the remedy part? No, because it's the understanding of the whole of the person in the context of what, if I just use first person, in the context of what's my capability of understanding it. So what's Linley's capability of understanding it, what's Ilma's, what's Caroline's, what's Celeste. So, and somehow this is part of the case as well. And a lot of the cases that we read don't necessarily contain that. It's maybe assumed that we will know, but sometimes cases don't even say what methodology the person's used to come up with whatever they've done. So, that too is another depth of digging in and bringing things up to the fore. But one of the key things that Ilma just mentioned too was that asking the patient for their complete feedback on the experience that they've had with the treatment. And this is actually one of the criteria in the guidelines. It's down there at number 13. It's like the last one. And in the medical guidelines, I think it says it's optional. And so at the beginning of the process, I said to Ilma, well, can we ask her patient, would he be happy to give his feedback? And we agreed that whatever it was, we'd publish it, whatever he said, like not edit it. So if he came back and said, well, it was kind of good, but, I think blah, 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 and it wasn't, very favourable, we would have put it in. But he blew our minds. Like we couldn't have imagined what he would have said. And all of a sudden it opened up the realisation that we're not asking people. I can't remember reading a case where in any of our literature where the patient's view on their treatment has been reported in their words. The patient got better, the patient was happy. That's me observing the patient. It's not them saying what an impact it's had on their life, and how they've changed because of the treatment. that seemed like an incredibly powerful thing to have in a case report. It's not the core, but it's kind of like it's like an overcoat or something. It sort of like holds it all together in a very unique way. So that's where I wanted to go with that, and I know when I read the patient's feedback, I was blown away by it, and I'm sure that Ilma was too. Sorry for moving my computer. It was just mind-blowing. And so with that, I just wanted to go to our last question, which is maybe a little bit tricky, and you sort of started talking about this a little bit, Caroline, too. Is what do you think is important to include in a case report? Because we've got the home care case reporting guidelines, which I'll show you in a minute. But if we just talk amongst ourselves about what we think is important, that could be useful. There could be something missing, or if you like the things that we think are important, maybe they're the things that we highlight more in the case report. So I'm going to pass that over to Lindley.
Well, I'm just thinking it might be super important to have a copy of the guidelines and the home care guidelines and lots of info. We'll put it in a folder in the members area so that everyone can access it easily, because like Caroline's saying, where do you get these guidelines? So let's do that. Let's keep it really easy for people to find. I think that's something we haven't done and we need to do. And I think it's important. Some of the words I'll just pull out from. I'm really looking forward to reading your case history, Ilma, because you said it's a beautiful thing to have the patient's voice there, but it's much more than just the patient. It's much more than just being patient-centered. What Celeste says it's unique and mind-blowing, and I think, God blimey, you're going to have a sellout issue of Similia the next time when we start writing things up in this way. But it's the inclusion of the whole process, which is, I think, it's a beautiful thing. There's a lot of emphasis on the patient-centered approach to writing up a case history now in nursing and all different kind of professions. But what we're talking about is really honouring our profession and including our whole process, which is, of course, it's holistic. It's not just the holistic medicine. It's not just the holistic way of taking a case and looking at the whole person and their family and everything else. It's more than that. It's the homeopath, you're saying, include the homeopath and the self-reflection and their voice. And it kind of makes me think about when you read a novel written by someone who writes so beautifully, you don't even notice how they're writing beautifully. And they start off with these, it was a sunny day. They're setting the scene. The cat died yesterday. They put the emotions in there. They've got the weather. They've got everything. They set the whole scene. And before you know it, you're sucked in and you can't put the book down because it's so damn interesting. I think... I'm not saying that we're going to start writing case histories where we tell you about the weather and the cat dying, but that whole setting the whole scene to include the whole process. That's what you and Ilma, Celeste and Ilma, that's what you're saying. And I think, like in the past, some people have made it into an art form to write little tiny case history, like Burnett. I gave the person Bellus perennis. It's like giving everybody in the universe Bellus perennis. And they all did marvellously well. And we're reading his book so frustrated because we want to know, what potency did you use? How often did you repeat it? How many months did you give it for? Did they end up having surgery or not? All you get is this tiny little thing. It's so frustrating. But we're trying to do the opposite of that, really honour our holistic profession. I think that's where we're going with this. And there's so many things that it's important to include, but I think some of them are just obvious, like you really need to have had a good year's follow-up before you start writing up a case, some obvious things like that. And did they really get better from the homeopathy, or was it the acupuncture they had every 3 days since the last 6 months? You know, those kind of things. It's obviously we need more clarity around that stuff, but this other bit is the beautiful, exciting, mind-blowing bit where we put everything in there about our emotions too, sometimes about, you know, wow, that'll be the day, won't it, when we start saying, you know what, this person came for 6 months and I really needed help after looking after them. You know, that would be mind-blowing.
That'd be a case.
So that's my answer for that question.
That's awesome. Thanks, Lily. Caroline, what are you thinking?
Yeah. Well, when Linley said that, the first thing I thought was self-care, you know, because that's been on the radar for a little while now, about how we've lacked self-care and how we read ourselves, and what that dynamic is between the practitioner and the client, or the patient, or the other person, or whatever you want to say, or the family, if you know, how you're responding to them, what they think of you. I mean, all these things come into it, don't they? And yeah, it's not just about the remedy. And I think that needs to all be incorporated, but in a small amount, but very succinct. And as I said before, it's so important to understand why that remedy was chosen and how that person responded to it. And as Linley said, what else is going on in that person's life? Are they having acupuncture or whatever else as well? And most people don't tell you that. They just, you can give me something homeopathic for this, can't you? And that's it. You give them something. You don't know if they've what's the word, neutralised it, antidoted it or something by doing something else. Yeah, it's very difficult. So writing a comprehensive case is not a simple task, and to be really comprehensive, it's quite lengthy. And I guess the skill comes in when you can condense that to the most important relative thing, and at the end of it say, oh, that was interesting. It was like listening to a story. This is why I like reading so many of the cases from European homeopaths and England and America. I've subscribed to Spectrum since it came into publishing, and the cases there are just brilliant. I mean, you know, the way they're written up, and I've always taken notice of that. That's probably why I've never written one up, because I thought, well, I just can't, you know, it's difficult. But then you've got to have the time, you've got to have the opportunity, you've got to have the resources and the capability on this technology and all the rest of it. So, yeah. Yeah. So what else would you include in it? Well, there's quite a list. I have many lists of all sorts of things. But, yeah, I think number one, it would depend on whether the case that you're writing up is really a really acute situation, or an exacerbation of a chronic situation, or something like that. And I think that is the primary, it needs to go under that title. So you have different areas. So not everything is the same. You've got different criteria for different situations. Yeah, and yeah, okay, I'll leave it at that.
Okay, that's great. Ilma.
I think what we've done, Linley and Celeste, Caroline. In doing this, I would have taken into consideration other orthodox drugs or other orthodox treatment that this person was having. But I don't think, without your help, Celeste, that I would have actually read papers on it in the way that what the orthodox or traditional people actually treat this particular complaint with or like, and how they kind of tick boxes of, well, we'll try this, and if this doesn't work, we'll do this. And it all seems to get kind of, for me, more invasive as you go down the list. And it's pretty frightening. But to know that those are the stages that generally a person who's being diagnosed, especially with this disease that I've been working with, or this complaint, Meniere's, it's been an eye-opener, you know, in the way that he's changed a lot of his life because he's that type of person, to comply with what his specialist says or what his doctor says. And then you read these papers and they've changed part of the things that they're prescribing, but they haven't actually brought it down to the patient's knowledge. So he's still kind of doing without certain things because they've told him to do it because it's going to be better for his problem. But in some of these papers, they're saying, well, we no longer use that because it didn't matter anyway, because it didn't get any, you know, a good result from it. So that to me has been really interesting. All the holes that are there that we don't really know about. Well, I didn't know about it without reading papers on this particular complaint that have been written by the traditional medicine people or orthodox medicine people. So, yeah. And I think that we've highlighted just a couple of these things in the report as well, with the information that we've got. And I feel that that kind of fills it out to make them aware we've not been completely just one-sided with homeopathy. We've taken the whole picture and considered it and gone down the path of homeopathy, obviously being a homeopath, but haven't told him, well, you must stop this and you must stop that and you must do this. It's a matter of working with all these other things, but it's not until you read their papers that you realise some of it's a load of bumpkin.
Well,
Sorry, that's how I think.
It's okay. It's an interesting thing because it's like I think there's an underlying belief that it's the absolute truth.
Yeah.
And then you discover, oh, actually it's an opinion, or it's an agreed upon situation, which is actually very fluid and is changing. But sometimes those changes don't filter down to this particular specialist or this particular country or this particular GP, you know. And so there's kind of like, there's no one fixed thing, but I think there's a belief, a false belief in us that says, oh no, well that's the thing, you know, the treatment is going to cure, or the path that they're offering, then they actually know where it leads. And as soon as you move into incurable chronic disease, that's not the case at all. It's a very, very flexible situation. But I think what's important from my perspective for our case reports is to place them somewhere. So that's kind of what I see the case reporting guidelines allowing us to do, or suggesting that we do, is that we're using a particular methodology, homeopathy, to help a patient with a particular diagnosis or series of issues. We go with the patient-centred approach, but still they come with either symptoms that are like something, or they come with a diagnosis. And so they do sit this is kind of like a bridge between two ways of looking at things. And I think it's useful. I think it would be very useful for us to be able to, to begin to map out those places where this particular experience is being recorded, so that it exists in something. Like, it's not existing in a vacuum. When the patient doesn't exist in a vacuum, our treatment doesn't exist in a vacuum. And it can be very, complicated and interconnected with other activities and treatments going on, some of which the patient may not want to be on, and others which may be essential. So, we're not in a position to say it's right or it's wrong, but that's where the case is. And I think building that landscape more, so that when people are reading the case, they understand that, could be very helpful. And even though, say, Ilma, in the case that we're working on, on the Meniere's, the gentleman with Meniere's disease, it could have been another case where somebody came with vertigo-like symptoms or tinnitus-like symptoms. They didn't have a diagnosis as such, and or they had vomiting. Maybe they had all the symptoms of Meniere's disease without a diagnosis. But then maybe the way that the placement of that is in the recognition of these kinds of physical symptoms, or maybe the case is written in a recognition of, the quality of my life has turned from here to here. It's gone that way, So there's some way of doing it. Anyway, that's what I kind of think. And that's like an expansion out rather than the contraction in, which is sometimes a lot of the cases we might read are kind of very restricted down to remedy, symptom, outcome. Anyway.
But we have to be contained. It can't get too big.
No.
It's all interesting.
It is.
Well, what do you mean exactly, Caroline, when you say it can't get too big? What do you mean exactly?
Sorry, repeat that, Linley.
Yeah, well, I just wanted to know, when you said it kind of can't get too big, I think I know what you mean, but what do you mean when you say that?
Because if there's too much information, it just gets lost in itself. And it's like a needle in a haystack.
Yeah.
Looking for the essence of it. The essence of what you're trying to say in a case, I guess.
Yeah.
You've got to have some, guidelines, You've got to have a pathway. You've got to have, So it's not like in orthodox medicine where you have something, you name something, and you try and fix that thing, but then you can't fix it, so you send them to another specialist to do it. We're those 1,000 specialists all rolled into one in a way. That's what the holism is. But then trying to concentrate that into being effective on all levels, but keep it comprehensive, but keep it within certain parameters. Does that sound rather gobbledygook?
I think that's good. Yeah.
No, not at all. Yeah, not gobbledygook at all.
Thank you.
Yeah.
What I've just done here is I put up the summary of what these guidelines are, because and some of these guidelines are like very simple. Informed consent, a title, keywords. The reason they're here is because, over the vast amount of things, sometimes these things are missing. And then we've talked about a few of these things, but already, but you'll see here, I wonder if my mouse will, can you see my mouse?
No.
No, okay. All right, I'll go this way. Can you see my mouse?
Yeah.
Yes.
Yeah, okay, beautiful. So probably the key aspect of the guidelines really lies in, like if we've done our case taking, there'll be kind of a series of consultations, notes, potentially rubrics, prescriptions, follow up. There'll be that kind of flowing on timeline of activity, and it literally kind of falls into this kind of area here of follow-up and outcomes. So there's quite a lot of things that we already do naturally in our case taking, which fill out a lot of these areas. But then there are extra elements, if you like, that maybe we could explore a little bit more deeply, just to build the context of how the case comes together. The issue around this particular 13 guidelines, if you like, is that when you read the paper, it can be like, oh, and it becomes like a bit of a document and a bit hard to connect with in some way. And so I guess that's really the process that me and Ilma have been going through together for the last couple of months, is to start where we've got the clinic notes and then work from there, expanding into all of the areas of the 13 particular guidelines. The really interesting one here is discussion, because this is really where you get a chance to talk a little bit about the strengths and limitations of what you did. So it's like a self-reflection in a sense. You might also then in that time reflect on your case in the context of other cases on the same type of situation, depending if there's a diagnosis or not. And there might be some other cases that have been published that are worth making some reference to. And then also an opportunity to think about, why did you come up with, how you came up with it, like what your conclusions are. So they're kind of, quite putting the spotlight on what you did as opposed to how the patient responded. So that's like an extra element of something. I suppose it's about practice management or case management. So that's where, from colleague to colleague, there might be something to be learnt, or some insight about how a different person has dealt with a problem that maybe I have a similar problem and I see a difference in how we did it, and so I learned something that way. What else can I tell you? And then the patient perspective is the interesting, I think the really interesting part. And the rest of it, the timeline is further up, which is, I think the timeline is a really neat idea. We have the timeline in a lot of our cases when people are showing, one consultation to the next, what's going on, but it kind of all becomes connected and hard to see a snapshot of changes. So this is the idea of extracting out key things that are happening across time. And it can be before you see the patient as well. So there can be historical time of the patient's history in that timeline that's relevant as the timeline goes on. There's a lot of possibilities on looking at how things come to be in the case itself. And, like I'm looking at this here and I'm thinking, this is not very difficult. So I come back to myself and go, well, why haven't I done it?
Yeah.
Maybe I missed something there, but do you think that actually documenting, if you do take a particular approach, like in the homeopathic analysis, if you like.
Yes, absolutely needs to be there. Exactly what is the thing that you did? That is crucial, because whatever your homeopathic technique is, it's not necessarily mine. I mean, we follow some basic principles, but, but if you're using the sensation method and I'm using levels of health, completely different. I mean, in a sense, the way that the whole thing is working itself out. But you need to say what it is. Like how are you doing a consultation? How are you asking the question? Is there a questionnaire? Are you just asking clinical questions? Do you sit there and just wait for the client to tell you what's coming up? Like all of these things matter, and that's part of the method. And that's that's a bit that sometimes is missing in the case reporting, because the focus is on the remedy. These are the rubrics, this is the remedy. How did you get the rubrics? How did you get the remedy? So I repertorise with the program. No, I know my materia medica, and I just know that this particular set of things is carb. So tell us. It's not like it's wrong. It's just tell us what you did so we know. Because it's not like you'll be repeating it, because you can't. This particular client is, and the time you saw them is the only time that this is ever going to have happened. And the next time they come, it's going to be different again. So, but that sort of like helps us move into the space of understanding what it is that's gone on, so that then we can see with clearer vision what the process is, and in that place learn more about the theory into practice. That's, for me, that's really the heart of it, I guess.
And like what Lindley did just, a few moments ago, when she asked Caroline, what she meant by the statement that she made. I think sometimes we can miss those things which are so relevant that they can open up a whole other area of how that person's feeling with their sickness, let's say. Yeah.
I lost you.
You lost me. I'm still here.
No, I lost you all. I dropped off the planet, yeah.
No, when Lindley asked you to explain what you said there just before, the few words that you actually mentioned, and Lindley said, I think I know what you're saying, but can you just explain what you mean? And then you went into more explanation of what you meant of the picture. No. Can somebody else explain to her?
No, it's not that, Ilma. I think her internet might be dropping in and out.
Yeah.
So you're talking to me.
Yeah.
Sorry, that's what I mean, you see. I lose the thread of conversation because I lost you. So sorry, ask me again. Are you asking me something?
No, it wasn't a question. It was just a kind of a reflection.
Oh,
yeah.
Okay.
It was an observation, really.
An observation.
Yeah,
right. Yeah. Okay. Yeah. It's one thing to talk about it all. It's another to actually write it down.
Yes. Exactly.
And succinctly. Yeah.
That's why it's good to have a guide.
Yeah.
Yeah, but then
Totally.
the guide isn't quite sufficient. I want to put something else in. Yeah, some of us are born writers, others not so much.
Well, I think the other thing is that it's not just that writing, because like maybe if I gave you my case notes, you would go, oh, I can easily write this up. And if you gave me yours, I could say, oh, not a problem, I can write that up.
No, you couldn't.
No, you couldn't.
Maybe. But the kind of like writing up your own kind of shines that spotlight right back into some things that are worth exploring. And as Robert said to us,
Yeah.
basically sit in an uncomfortable space for a while, which he said human nature is that we don't want to. We don't want to be uncomfortable. So
And I think
we're off.
the other important thing there is that most of these kind of things in our profession, we feel like we have to do it by ourselves. We have to work in a little silo by ourselves, but we don't have to. We can write up a case with somebody else holding a hand, or with a true collaboration. We can do things together, and it always makes. Well, Van Hasselen said, just sit there and let yourself be uncomfortable for a little bit. It's absolutely true. You just got to open that, open the gate a little bit. But opening the gate is a lot easier when there's two people, one pulling one door and one's pulling the other door. So I think that's the one of the missing links when we do it with a friend or a colleague or somebody else. That makes it so much better.
Well, I just wanted to say thank you very much for all of us coming and sharing, because I think it's the beginning of a good process, and I really acknowledge what Lindley just said, because I think one of the plans is to start some case reporting workshops, so that people who are kind of teetering, thinking maybe I've got something, but maybe I don't know how, or I don't want to do it alone, working together with others is the way forward, I reckon. So that's something that we're going to work towards creating, which would be very helpful at any rate, and also give us, CBD opportunities, and help us build that sharing of our cases, because like all of us, I know that when we meet at a coffee station at a conference and we've all got a case to talk about with somebody, it doesn't take too long before we're talking about, there was this really good experience of blah 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 blah, and the case comes out, and it's kind of like, wow, okay, there's a lot of those experiences of interesting cases, and when I say interesting because of why, because it worked, because it was an unusual remedy, because it was a good feeling from the patient, because they got really better. So, exploring how homeopathy really helped them in that space. These things, I think, would be good to continue recording. But just in conclusion, do you want to do one more round and just make some concluding words?
Sure. I can go first, happily. Carolyn was talking about Spectrum magazine, and I just think that's a great example of cases written up that are readable by the general public too. A good while ago there was a kelp carb case, I think it was sinusitis, and it was so beautiful that I asked the author, could we use a snippet of that case for a blog on the Aurum Project, and he happily said yes. But that's a good example of just a basic case. The fundamentals of the case were really basic. It was a good kelp carb case, a clean old sinusitis, if I remember rightly, it was sinusitis. And I think you can write up any case and make it really interesting. And I don't know where I was going with that, but that's my concluding word. That it doesn't have to be fancy smancy. I think that's what I was trying to say. That a good case can, be written up, and it doesn't have to be curing MS or something. Yeah. That's my last word.
Thank you, Lindley. What about you, Carolyn?
Yeah, well, I can. Aconite has been a mainstay for one particular person. not just in the acute situation, but I feel it's had a great impact on the chronicity of the problem, which has been going on for years. And it works brilliantly every time when I give it for particular reasons that I give it. There you go, you see, it makes it a very complicated case because there are other remedies in between.
Yeah.
Yeah, so I guess there was another case of giving pyrogenium. Just off the top of my head, I thought, just give pyrogenium. This person is working up to maybe septic shock or something. And it averted that, and I know it averted that. I mean, I felt it in my gut, but I also could justify why I gave it. It was like I could see it was doing something, even though they were then put on antibiotics, but that was out of my control. And I just smiled and thought, oh, well, yeah, you go do that. I've already fixed it, but that's okay. But the problem was because of the orthodox approach in the first place. That makes it complicated. So, but the essence of that is that I could see how pyrogenium really works so well, just one dose. And as I said, the classic symptoms of going into a septic state were just so obvious. And I thought, at the time actually, I thought, oh, I should write that up. Yeah, but, it's so limiting, I guess. Is it really interesting? Is it really important? Is it really striking? Does it need to be striking? Does it need to be...
Yeah, that's the thing. That comes back to that's, how do we feel about it? So...
That this is probably mine, reservations and...
Yeah, I think so. I think so.
I'm comfortable in myself, but I'm not comfortable telling everybody and making it sound like I'm sprouting something. I don't know, I just... Yeah.
Yeah.
I'm just that sort of person that works on my own. I find it difficult to. I've tried many times to integrate with other practitioners, but yeah. Ilma? Get me out of a rut here.
I go with the flow. I love having people around to discuss things with. I always find that I learn something, and I think Melting Pot has always been a great way of bringing people together, regardless of how we all kind of think. When we come together, we tend to find a common denominator there, and it doesn't matter what it is. And I always come away feeling quite joyful and as though I've learned something. Maybe I'm just really easy to please, but I don't have as many questions as what a lot of you have. I just do it.
Oh, it's cool. It's very cool.
Yeah, it's all unique. That's what I think.
What am I feeling? I'm just feeling like we're just beginning. And it's good. And, and we don't have to do everything, but there could be something that could be done. How's that sound?
Yeah, and I think as long as the guidelines that we're kind of figuring out are there to share with people, that's a real help to people if they decide to do it.
Grassroots.
Yeah.
Yeah, totally. Because, grassroots, and we don't have to do it alone. I
Yeah.
think that's the
Yes.
other thing.
And to have a sense of humour on the way.
With that concluding remark,